Great. Thanks. Let's see what Dr. Watson's up to. Our next case is a 70-year-old man with a history of chronic HBV infection, HCC, and portal hypertension. A recent upper endoscopy in August showed esophageal and gastric varices. Recent labs showed platelets of 86,000, INR 1.3. He's been referred to our center for EUS-guided embolization of gastric varices. Let's go to the room.
All right, guys. So thanks for the introduction. This is a gentleman with chronic Hep B. He's got esophageal varices, gastric varices. We just did our diagnostic EGD. He apparently had a rumor of a previous GI bleed, though he just came into our care here through our hepatology service. So what we're evaluating now is our gastric varices and whether these are going to be amenable to EUS-guided coil and glue injection, a procedure that was pioneered here by Ken. And it has been shown in this form in the past, so I won't belabor the history, but more some of the technical nuance here of looking at these varices. So I'm down fairly proximally in the stomach. I'm flexed up, trying to sort of almost retro into the fundus here. I've injected a couple of syringes, 60 cc syringes of water, just to help me delineate where the varices are. Just off the cuff, you can already see, okay, we've got some tubular structures here. We can throw some Doppler on, and there you can see some flow. So this is, for the football fans, reminding me of NFL Red Zone here. We're just going straight for the highlights. So here we can see a large conglomerate of varices here in the fundus. These are looking like IGV1 or isolated gastric varices, maybe even starting to look like two, but essentially one. I think the installation of water is very helpful here so that I can kind of see where the varices are in relation to the wall. If you look over here to the left side of the screen, you can see he's got a little small complex there, but fairly small. Obviously, here's where we're going to concentrate our efforts. The challenge, I think, as you're doing these procedures is determining, especially with a complex this large, where are we? Are we in the lumen or are we out beyond? And here you can see clearly we see the spleen here inferiorly here, and these are actually collateral vessels that are extraluminal. And then as we transition here, we can see now we're within the lumen. And so what can really help me is, again, that water installation to see. There is the question of now, do we look for a shunt? And I know some folks are injecting contrast to look for that. I think with placement of the coil, I think that really helps us in terms of obviating the need to do that. With the coil placement prior to glue injection, I think we're in good stead in terms of mitigating the risk of migration. So as we approach, we're injecting Dermabond here. If we just want to look at the entire complex, here we'll say just about maybe 2.5 centimeters by 2.5 centimeters there. And of course, then you can see the extraluminal feeders out there, and we don't want to get enamored with those and start injecting there because we do then run the risk of embolization. So similar to, as we're placing an access, we're looking for a nice runway where we can place the needle. We're going to start off with a 19 gauge needle here to facilitate the passage of our coil. So if you can see here, I think we're all confident in saying that this is all intraluminal, right? You can see kind of the rugal folds, gastric folds, and some of the water I've instilled. I'm eyeing this vessel here as maybe the feeder because all of this to the left, those are all intraluminal, and that's intraluminal. But as we come back and I sort of counterclockwise torque, we leave the lumen. You see that? Now we're sort of extraluminal on this guy right here, this vessel, right? And now we're definitely extraluminal. And then as I rotate again now clockwise, we're back into this nice big juicy varix. So that's going to be our feeder. You can also target that feeder vessel itself, or if you have a better window, you can come out here. I don't think there's necessarily a better way to do it. Welcome back. So we've just been hanging out here, taking a look at our varices, contemplating all the ways that it can bleed. So I think this intraluminal segment here, again, just to recap, he's got a couple of large complexes actually, but I think this guy is our feeder. And again, with counterclockwise torque, we're going extraluminal here. Now we're coming back into the complex. So I think That's where our feeder is. We could target the feeder itself or the complex, depending on what we think is the best runway. The reason being is we're going to be placing our coil, and we really want, as the needle comes out, our 19 gauge needle, to have a nice runway here where the coil can actually enter the varix and coil nicely in. If we don't leave enough room, sometimes what happens is that you'll push the coil and it'll just pop out the other side. Now, obviously that's suboptimal, you can cause some bleeding, but as long as you proceed with the procedure, have the majority of the coil in the varix and get your glue in, you should be fine, but of course a little less elegant that way. All right, so right now, I have a 19 gauge needle. It's primed with sterile water, and we're going to use that to access the varix. One of the few times you use an FNA needle, you don't have to put Doppler down because we know that there's certainly plenty of flow in here. So I'm just going to push our stylet out a little bit. Okay. And again, there's a lot of larger vessels that are extraluminal we have to be careful about. We don't want to be dropping coils there. You kind of want to get into the varix, a little sharp staccato stab. You don't want to go too far, cause bleeding. Again, a little less elegant. But on the other hand, if we go too slow, we can cause the varix to tent, and that can be a problem. And you can actually already see, so I cause a little bit of bleeding down below, so it's a little less elegant. But on the other hand, if you push too slowly, you start tenting the varix, and then if you deflate it, it becomes very difficult to actually get it to behave. So Julie here just aspirated blood to confirm that we're in the varix. We're loading the coil onto the needle. Maybe if we can get a room view. Okay, we got it, good. So that you can kind of see what we're doing here. She's sort of backloading the needle on, backloading the coil onto the needle. Okay, and right now I'm using a 15 by 15 coil, so pretty big. But the goal being is to use a larger coil in the hopes of mitigating the need for the use of glue. We're having a little issue getting it out. So you can also, the argument can be made too, well, if you're putting in coils, do you even need the glue at all? And I think that practice-wise, I've seen some success, and particularly with smaller varices too, you can actually get a coil in, and just with one coil and observation, you don't have any more bleeding, and in that case, we don't run the risk associated with glue placement. So that's one advantage. I don't know, Chris walked in here, Dr. Thompson, but his group is actually exploring the use of gel foam as well, and that's also an option, again, to help avoid the risk associated with glue injection. Mainly on availability, we've been using Nestor coils. Another question that comes up is where do you get them, and we just steal them from our IR colleagues. So that's what we've had available to us. Again, I think an advantage would be the larger coil you can get in there, the better, because then you're probably going to create a better scaffold for a natural sort of clot to form as well, and if you inject glue, then for that scaffold to hold. So as large as possible, usually we guesstimate about 1.5 times the diameter of the varix. And it looks like we're having technical issues here. All right. So I think, so we're having issues with the needle for whatever reason, so I'm going to have to pull out. One of the downsides of sticking and missing is then we can decompress the varix, right? It's going to make our next stab a little bit more challenging. But we'll go ahead and pull out here. Fortunately, these are quite large, so hopefully we'll be forgiven for this. And you can see they're basically staying pretty well inflated. Okay. So again, a standard 19 gauge needle going down. And again, we'll target our area. We already got. Yeah, so we'll typically give them intraprocedural antibiotics and keep them on for 5 days. Again, as we may have discussed previously, not the most scientifically driven thing, but we are accessing a sterile vascular space, and so we have to be careful about that. Okay. Yeah, so sterile water in the syringe. We aspirate to confirm that we're in. Every time we aspirate, we have more water to ensure that we're not clogging the needle with blood. So interesting thing about this procedure is I think, again, that what we discussed previously, the cognitive aspects, um, when to treat these, which patients, and then identifying your target accurately is important. Once you actually stick the varix, actually most of the work is being done by our excellent nurses, Mike and Julie over here. I'm basically just playing statue while they do the exchange. So our coil is in, it's in the needle. We're now advancing the stylet to advance that coil into the varix. Okay, I'm going to pull the needle back so you can start to see as the coil comes out here. All right, you can start to see the echogenic coil come into the varix. You can see it, go ahead and push it through. It's a longer coil of 15 by 15, but I think the advantage here is it's a very large complex. We want to get as much of a coil into this area as possible. You can see a nice echogenic signature from the coil and occupying a fairly good amount of volume here now within that varix. Okay. So now we've aspirated again to confirm that we're still in the varix. Sometimes as you're pushing the coil out, if we're not totally certain of our position, it can push us out. So we want to make sure we're still within the variceal lumen before we inject the glue. Okay. So again, we're using Dermabond. It's a little bit slower in terms of polymerization, maybe 3-4 minutes or so. So with our first injection, we're just going to go quickly in. We're putting in 2 cc's. And the second, you can start to see the glue sort of entering the varix there. You get a nice echogenic blush as well. And then with our second syringe of our 1 cc, we're going to go rather slowly and give the glue an opportunity to polymerize and sort of, again, mitigate that risk of embolization of the glue. And this essentially is an appropriate view that you're going to have. Again, I'm playing statue. I'm just sitting still as Julie's slowly injecting the glue. We tend to inject over 45 seconds to a minute, actually, to give it a good chance to polymerize onto the coil. You may notice also as we're injecting, so this was sort of the lateral aspect of that same variceal complex. And if you can appreciate, you start to see some hyperechogenicity here. You're starting to see actually some sluggish flow in that region. And I think as you start to do this, you can appreciate now that we don't necessarily need to treat every visible portion of the varix, but as long as we're getting close to that feeder, then we can go. Good? All right, so we've injected our glue. She's now flushing the needle to get all the glue out. And I'm actually going to just now pull out to clean off the needle. And you notice I didn't pull anything back out of the channel, so I'm pulling the needle back so that we don't have any glue that can stick on the transducer, because that would be a big problem. All right? So I pull out and lock the needle. Now, obviously, once we've run glue through this needle, we're done with it. Okay, so I'll run back down and take a close look and see how the varices feel. Just before we go, you can start, now you can really appreciate the coil in there as well as glue, and you can see laterally how much of an artifact we do get in the remainder of the varix there. So actually, that's a great initial response. I'm happy with that. And then we'll kind of observe, and we can throw our Doppler on too to let us know that there's really no flow in that area. And it looks pretty good. Looks pretty good. And there you can see the coil there. And even in these areas here where we didn't quite get, because it's all a closed system and they're communicating, there's really no more flow up there much at all. All right. Some quick follow-up here. So I just want to show you the endoscopic view after our glue and coil embolization. You can see the varices up. I didn't show you a pre-picture, but at least you can start to appreciate that up here, the varices there at 11, 12 o'clock are looking rather pale and engorged. That's a good sign that we've got good thrombosis within the varix. And then if you can switch me over to EUS, and we'll show that view. All right, so now we can kind of appreciate our large complex. If you recall, I ended up placing that 15 coil and 2 cc's of glue. I also saw a second complex over here. So while we were away, I just placed 14 by 7 coil alone. And you can see occupying that varix there. So we've gotten good good treatment of these varices. So just a quick follow-up there. So generally with these folks, we'll bring them back in anywhere from 4 to 6 months and take another look. Typically, you only need one treatment. Occasionally, need two if they're particularly large or if there are multiple points. So yeah, so with that, we can send it back to Chris.